Hi, my name is Michelle Gradecki, and I'm going to be talking about the impacts of language modality on language development in deaf children. Hearing loss is the most common birth defect in all parts of the world. In industrialized nations, approximately 2 to 3 out of every 1,000 live births result in a child being diagnosed with a hearing loss. In developing countries, the number can be as high as 28 out of every 1,000 live births. Looking at developed countries such as Canada and the United States, when you factor in postnatal reasons for deafness, which could be an infection, a drug, an injury, that number of children impacted by hearing loss climbs to 6 to 7 children per 1,000 live births. Children who are diagnosed with a severe to profound hearing loss generally are prescribed a cochlear implant, with approximately 80% of children receiving those currently in industrialized nations. Despite the fact of the introduction of newborn infant hearing screening, continuously advancing hearing technologies, earlier and earlier cochlear implantation, and early intervention strategies, we are still seeing a large percentage of deaf and hard of hearing children failing to meet age-expected language outcomes. Because of this, there's the long-standing debate of whether or not the use of sign language impedes the development of deaf child's spoken language or deaf children's language in general. In fact, some treatment teams have gone as far as to ban or strongly discourage the use of sign language in an effort to prioritize spoken language development. And this is regardless of the level of hearing loss a child is experiencing. This was discussed in a paper written by Hall et al. From 2024, pardon me. The purpose of this presentation today is going to dive a little bit further into this and ask the question, does the modality of language, whether it be signed or spoken, impact language development in deaf children? It's really important when we're talking about language development to understand the language centers within the brain that are responsible for language development. So I'm just going to get my little clicker here. So you will see here that we have Broca's area, which is located in the inferior frontal gyrus. So Broca's area can be split down the middle here into another area here, which it's split into two halves, pardon me, which are making up something called Brodmann's area. So you'll kind of hear those terms used interchangeably throughout this presentation. Just understand that that's kind of this area here of the brain. We also have Wernicke's area, which is just located here, which is in the superior temporal gyrus. It's part of the middle temporal gyrus and the inferior parietal and angular gyrus, which is in the parietal lobe. So these centers all kind of work together. The angular gyrus connects these two portions, the Broca's area and the Wernicke's area for receiving and sending language. So throughout the presentation, when I talk about primary language centers that are being processed and where language is being processed, this is what you just need to visualize: the brain and these colorful areas. So areas in the brain that language processes, it actually does change over the lifetime of a child. So in infancy, language is processed more posteriorly, pardon me, in the back of the brain and bilaterally. So both sides of the brain are processing sounds and language in different ways. As the brain develops and becomes more mature, the processing of language becomes more left hemisphere dominant, and it is more anterior. So Broca's and Wernicke's and a lot of language centers you'll notice are very left dominated, and that will be really important as we talk about some things later on in our presentation. The key language areas in the brain, they are very plastic, and they go through a neuroplastic period in which the neural pathways are being strengthened and then they become myelinated, allowing for the understanding and production of language. So during that period of neuroplasticity, that is called the critical period of language development. So research has shown that from the age of birth to age 5, and one could argue even pre-birth because the fetus is exposed to sound in utero, up until age of 5, this is when that area of the brain is really developing those centers. The research is showing that the window of language development begins to close and slow around the age of 3. Mayberry and Kluender in a 2018 study suggested that language learning is actually a hierarchical process that is linked to phonological structures of lexicon, morphology, syntax. And without these structures, it is impossible to develop a comprehensive communication system, which includes reading and writing skills in your first language. So when developing a first language, it's really, really important for a child to be able to develop phonetics, morphology, syntax, semantics, pragmatics, all of these little pieces of language that work together to allow us to communicate. So the language exposure that a child is given during the critical period of language sets up a reciprocal relationship between the building blocks of language and phonological working memory. And you require these things to ensure that there are efficient language skills. All later language learning is highly dependent on a child having a first full language. We call it an L1. And that first full language has to be developed during that critical period of birth to age 5. If a child does not develop a full L1, it is very difficult, if not impossible, for an L2, pardon me, for an L2 to be developed at a native level later. So brain imaging studies from the last 30 years have consistently illustrated that language is processed by the key language areas of the brain, regardless of the modality. So regardless if the input is signed or spoken language, we are seeing the same activation in the language regions in Brodmann's area, except for the initial period of language input. So when a deaf individual is provided language in sign language, the primary visual cortex is activated. When a hearing individual is provided with spoken language, the primary auditory cortex activates. However, after that initial activation of language through those sensory areas, everything else in the brain activates the same. So fMRI studies that were completed by Linus et al. In 2010, which studied deaf individuals, found that the secondary the secondary auditory cortex is activated when they are presented with phonetically structured sign language, which suggests then that the auditory cortex actually is multimodal. A study by Petito et al. In 2000 compared 11 deaf to 10 hearing subjects. And what they found was that there was bilateral activity happening in the auditory cortex and auditory tissues of deaf participants, but they did not find that in their hearing participants, which again would suggest that the auditory tissue responds to the structure of language versus the sound. Nishimura et al. In 1999 had done a neuroimaging study, and you can see this study here, again, which was looking at deaf individuals and where sound was activated. And what they found was in these yellow areas here, these were activated when presented with signed language. The green areas, which is actually in these little spots over here, are for audition, so spoken language. And then the blue areas here, these were activated when visual information was provided. So when we are comparing deaf and hearing brains and signing versus spoken language, Alan et al. Did a study that found the same regions are activated across modalities. The phonological processing of a sound-based language and a visually based language occur in the exact same regions of the brain. Sakai in 2005 found that the left regions of the brain are activated in the comprehension of both signed languages and spoken languages, which again would suggest that language networks are not reliant on sound and can process language across modalities. The studies have also shown that deaf signers do show more bilingual activity when processing language. And this is likely due to when they're processing signed languages. And this is likely due to the linguistic features that are carried on the face, on the hands, in sign language. McSweeney found this in 2012, so did Sakai in 2005. And then again in 2008, McSweeney had done a study where written English was processed in the left region of the brain by hearing non-signers. But the neuroimaging studies also indicated that individuals who were deaf signers or hearing native signers, when presented with sign language, activated bilateral cortical areas. So again, it's a multimodal mean of processing. There are a lot of myths related to sign language and brain development. Despite the fact that there's so much research that indicates that sign languages have a distinct linguistic rule and structure, there is still a widely held belief by a lot of medical professionals and auditory verbal therapists and individuals who work with deaf children that they believe that sign language impede auditory cortical development, which is therefore going to impede a child's ability to speak and develop language. This comes a lot from something called the visual takeover hypothesis. So Calvert et al. In 1997 was one of the pioneers in doing brain imaging studies. And what they observed was that there was an increased activation in the auditory cortical areas of hearing individuals who were processing visual speech reading tasks. So what this demonstrated was that the visual speech can activate in auditory cortex areas in hearing individuals. Therefore, there was a belief that came from this, not from Calvert et al., but from others who read the study and interpreted, is that if it was impacting hearing individuals, it likely impacted deaf individuals even greater. In 2017, Gerard and Lee completed a visual imaging study, a neuroimaging study, and they suggested that the visual processing actually takes over regions that are normally devoted to auditory input, which then potentially causes a decoupling or a deactivation of the primary and secondary auditory cortex. Because of these findings, there's been a huge influence of the visual takeover hypothesis across a lot of things, particularly early intervention decisions. Humphreys et al. Report in 2012 that sign language is actively discouraged or banned by treatment teams. And as a parent of a deaf child, I can also say that here in Saskatchewan, it often is and was to myself strongly discouraged with the belief that if my child used sign language, they would not develop spoken language. A lot of neuroimaging studies in the last 2 decades have really demonstrated, though, that the centers of the brain that previously were believed to be responsible for auditory only processing can actually be recruited and are recruited in sign language processing. And Hall et al. 2019 described this in detail. What they found, again, is that sign language processing is processed in the auditory processing areas. Bavelier and Novell in 2002, they found that sign language access does not cause the visual pathways to be stronger, nor does it drive cortical reorganizations, but rather suggests that these changes are the consequences of auditory deprivation, so not being able to hear, and that they occur independently of sign language experience. Pontecorvo et al. In 2023 have gone as far as to say that there is no well-designed empirical study that has proven the visual takeover hypothesis to be true. They talk about the fact that many of these studies compare deaf individuals to hearing individuals, hearing non-signers particularly, and it fails to account for early language access and how much or how little somebody received. They talk about the cross-modal visual the cross-modal visual activation in these regions is more likely due to lack of early language access than it is to sign language being provided. And so again, it strongly suggests that sign language exposure is not the source of this cortical reorganization, but rather the lack of a child having auditory input and access to language. So again, we spoke about it a little bit prior, but cochlear implants, again, they are the standard of care, particularly for severe to profound hearing loss. More than 80% of deaf children in industrial nations do receive cochlear implants. In Canada, the standard of practice in the majority of provinces is to provide a cochlear implant between the ages of 12 and 18 months, which seems really great when you think of the critical period of language being birth to age 5, that if a child is being implanted by the age of 12 to 18 months, things should be okay. But there's a little bit of problem with that because there is still a period of time before a child receives a cochlear implant that they're going to be without sound. The first part of that period of time is from birth until diagnosis and implantation. And then following the implantation, there's a post-surgery recovery, which is a couple of months before the child goes for activation. And then there's a series of mapping that has to take place within the cochlear implant to ensure that auditory signal is at optimal levels. So when we think about that, and how short of a time frame the critical period of language is, even 1 year, if a child was implanted by the age of 1 year of delayed language learning while waiting for a cochlear implant surgery can have huge implications for a child's future language development. Again, when we look at cochlear implant outcomes, Hall et al. Cited a study by Naparco et al. From 2010. And within that study, they talked about some children with cochlear implants showed a better spoken language trajectory than children who did not have cochlear implants. However, Hall points out that the cochlear implant users still did not achieve language outcomes on par or comparable with their hearing age-related peers. Multiple studies, Pierce et al. 2017, Del Conseri et al. In 2024, and Hall et al. In 2019, have all found that the outcomes for the broader population of deaf children typically fall below age-expected outcomes for their hearing peers, particularly among deaf children who received cochlear implants who had no exposure to sign language. Pontecorvo et al. And Davidson, they both explored this a little bit further. So Pontecorvo studied the vocabulary size of deaf and hard of hearing children with hearing parents who were learning sign language and English language at the same time. And Davidson studied 25 CODAs, so children of deaf adults. 20 of them were hearing and 5 of them were deaf, and they had to have at least one signing deaf parent. So that child was receiving sign language input from birth. Both of these studies found that the deaf children who had access to sign language prior to receiving a cochlear implant achieved much stronger speech perception and overall language outcomes compared to children who did not have any sign language exposure. So because the auditory signal that's delivered from a cochlear implant is not equivalent to natural hearing, Pierce et al. In 2017 talk about the access to full phonological and morphological structure of language and speech is reduced, which then increases the likelihood of impacts of phonological working memory. So again, when we think back to how long until a child has access to that sound when they were receiving their cochlear implant, and then the quality of sound they're receiving after receiving their cochlear implant, there is a lot of stress and pressure put on the speech that is required to develop full phonological and morphological structure. It's quite simple, really, in that speech does not guarantee access. And an accessible language that is signed is very critical for the development of neural pathways that are developing during that critical language period. Simply putting a child in a room with speech and sound does not guarantee that they're actually having access to it. And it does not guarantee that they are reliably receiving auditory signal. So it is really, really crucial that deaf children are provided with an accessible signed language as early as possible to ensure that those neural pathways are continuing to develop. Language deprivation is something that we rarely see in hearing children, except in cases of extreme neglect. It is caused by delayed or poor quality language input during that critical period of language development. So a child is not developing a complete native L1. The implications of language deprivation are vast. There's issues with language proficiency, with cognitive and social domains of the brain. We see significant impacts on memory organization, working memory, executive functions, sequential processing, concept formation, numerical abilities, statistical learning, theory of mind, and so many other neurocognitive skills. And this is not caused because of lack of hearing. This is caused because of lack of access to language. Language deprivation has lifelong and irreversible consequences for deaf children. Chang et al. In 2023 did a groundbreaking study that examined deaf adults who first acquired sign language between the ages of birth and 14, and they categorized these individuals as early signers or late signers. And the late signers were the ones who had restricted early language access and exposure. And those individuals that had that later exposure actually had a reduced cortical thickness and volumes in the areas that were central for linguistic processing and processes and meaning. So the Broca's area, the posterior middle temporal gyrus, and the angular gyrus. So all of these areas that are center of linguistic processing and meaning had developmental issues. They just were not the same as individuals who had early sign language access. And when they looked at individuals who had early sign language access, they actually found, in comparison with individuals like hearing individuals who had regular access to language, there was no distinction between the anatomical structures of the brain in early signers versus hearing individuals. But there were significant anatomical structure changes and differences in individuals who did not have early language access. Mayberry and Clowender in 2018 went as far as to point out that severe cases of language delay actually, when the brain was processing those languages, it did not do so in any manner that was meaningful and did not activate any meaningful centers within the brain. So it's really important to remember and understand that language deprivation permanently alters the architecture of a language system, and that by providing sign language at birth, that actually could prevent those adverse neural outcomes. We know that the brain needs linguistic structure. We know that sign language stimulates the same higher order language regions of the brain as spoken languages. Children that are born profoundly deaf or severely deaf, they are isolated from language in their environment just by virtue of their inability to hear. Hall et al. In 2019 again emphasized that deaf children who rely solely on spoken language for their first language development are at significant risk for failing to achieve age-expected language outcomes. And again, simply being around so that speech does not guarantee a deaf child is going to have enough auditory signal to build a foundational language. So it is critical for deaf children to be provided with an accessible language as early as possible to ensure that their neural pathways that are responsible for language continue to develop during that critical period of language. We know that children who have early sign language exposure during that critical period of language development, it's going to reduce their likelihood or the severity of language deprivation, and it leads to higher level language and literacy development outcomes. Humphreys et al. In 2012 and 2024, Hall et al. 2019, Linus et al. In 2013, Del Concere in 2023. There are so many studies that indicate that benefits of early sign language exposure is that it reduces like deprivation risks. We know that the benefits of early sign language and that children who have access to early sign language from an early age, they consistently show stronger phonological and working memory. They have improved literacy skills and they have stronger social and emotional skills. Findings from so many researchers, Allen et al. From 2014, Linus, Johnson, Pierce, all of these are in the reference page in this presentation. You will see that they continue to show that kids who have access to early sign language do better. Sign language cannot be a last resort option. Often, professionals ask parents to withhold sign language while they are searching and working on spoken language. And when that fails, then they are provided sign language as a last resort option. Mayberry et al. In 2003 completed a study in which they looked at the grammatical performance of late deafened individuals who had a complete L1 prior to losing their hearing and compared it with individuals who did not have early sign language access. And what they found was the individuals who had a solid L1 were able to develop L2 without an issue. However, the individuals who had late access to sign language really struggled with developing grammar structure, critical recall. So it's important to note that sign language is not a barrier to speech, but it's instead ensuring a deaf child has access to language so that they can properly develop a first language during that critical period of language. Which, of course, when they have a solid L1, that's going to help facilitate the acquisition of spoken and written language. Early access is key to language. Language is processed in the same areas of the brain, regardless of the modality. Sign language does not negatively impact speech or cochlear implant outcomes. In fact, it is the opposite. Sign language is proven to enhance these things. The language challenges that are faced by many deaf individuals are not because of their deafness. It is because of the lack of language that they are provided. And therefore, early access to language, signed language, is critical, as this is going to mitigate later cognitive, social, and emotional challenges. And it just sets the foundation for healthy development of deaf children. I want to thank you for taking the time to listen to this presentation, and I hope you have learned something today.